Hi, this is Dr. Deepak Megur. Let me demonstrate the principles of low flow, low pressure surgery, which I prefer to use in the posterior cataracts. Let us see whether this technique is successful in preventing the breaking of the posterior capsule. She is a 32-year-old lady who has this classical posterior cataract. It's present in both the eyes, and today I'm operating on the right eye. The surgery is being done under topical anesthesia. The patient is extremely cooperative and she's having good fixation to the microscope light. The two side port incisions are made. Intracameral anesthetic is placed into the eye under the air bubble, followed by using the trypan blue. Although there's a decent amount of red glow, I still prefer to have a trypan blue stay in the capsule because in certain tough situations it makes my life easier to identify the capsular margin. The chamber is filled with dispersive OVD. Care is taken not to overfill the chamber. I just want to keep the eyeball a little bit soft. The main incision is created, and at every stage of the surgery, I want to ensure that the eye is never overinflated because I have realized that overinflation is one of the primary reasons why the incidence of PC tears happens, and it is much more common in younger patients. In this case, I am planning an oval rexis, which I learned from Dr. Kiranjit Singh from Amritsar. The advantage of oval rexis is that you got better access to the epinucleus, and especially in the subincisional area. And this is a step where most of the posterior capsule tear can happen when trying to remove the epinucleus. So just having this oval rexis gives better access and maneuverability to manage the epinucleus. That's the principle. So I'm going to have the longer diameter in the direction where I'm sitting, that is temporally, and we have a smaller diameter in 90 degrees to it. So I got a decent sized oval rexis, which is worked out pretty well as I'd expected. So as we all know, we're not going to do any hydrodissection. So I'm directly going in with my phaco probe and I'm trying to do a small trench here. So this is a soft cataract, so power settings are extremely less. I'm just using about 40% continuous ultrasound in torsional mode. I'm using the Infinity machine with very low flow rate and a vacuum. The bottle height is set at 50 centimeters and the idea is to do the inside-out delineation as has been taught by Dr. Vasavada. This helps us to minimize accidental entry of the fluid into the subcapsular zone, which can increase the risk of PC tear. So the idea is to create a long trench, at least about 50 to 60% depth. Since this is a cataract, I'm hardly using any power. So I've designed a long, thinned trench, which is about 50 to 60% in depth. And now is the time to perform the inside-out hydrodelineation. The hydrodissection cannula is pressed across the wall of the trench as it goes into the substance of the nucleus, and then carefully a very small amount of fluid is injected into the substance of the nucleus from the lateral wall of the trench, and this provides us the golden ring, which is not very huge in this patient because she is very young. So we've got a very small endonucleus. I just try to repeat it on the other side. So we've got a sort of an endonucleus which is defined by this partly visualized golden ring. So now is the time to divide this soft endonucleus into two fragments. It's going to be difficult because the lens is very soft and gummy and it might not be easy for us to break it. So I'm just trying to go in with my phaco probe and the lens dialer and let us see how things turn out. So it's not possible to divide. What I'm trying to do is, we're using just vacuum, no power. I'm just trying to tease out this endonucleus out of the bag. It's coming out in piecemeal, but nevertheless, I'm able to maneuver the nucleus bit by bit out of the bag and into the antechamber. And now with my second instrument, I'm trying to mobilize the soft lens matter out of the capsular bag. It's taking a while for me to maneuver it. But in these cases, I think patient a great virtue to have. Finally, I get the purchase and some part of the endonucleus is maneuvered out and emulsified. The central plaque is still there. I don't want to mess with it. Maybe it's going to come along with this piece, and as I'm trying to remove this part of the heminucleus out of the bag, I can see that part of the plaque is already come along with it. At this stage, I'm a little bit concerned that whether the PC is open now. So let me just aspirate this soft lens matter and let me visualize whether all is well or not. So I'm just changing the settings to the epinucleus mode now. I'm using an ultrasound energy of just 5% in longitudinal mode, and we have a flow rate about of 30 and the vacuum of about 350, and the bottle height is around 60 centimeters, and the epinucleus is out. And now I'm seeing this red ring here. This is actually a good sign. This, although looks like an opening in the posterior capsule, it is not. Now this is a pseudo hole. This is the ring is formed by the termination of all the cortical fiber there. In my experience, I noted that whenever we see this ring or pseudo hole, actually these are the eyes where the PC does not open up. So before coming out, the OVD is injected into the antechamber. So I'm using a dispersive OVD, which is an Oro coat, an Indian mimic of viscoat. The cannula is very thin, it goes inside and we can push it out easily. Now in this red glow, we can clearly delineate the area of the what I call the pseudo hole, or this is the marking. And when we see this sign, actually the incidence of PC tear is relatively lesser in such polar cataracts. So now is the time for the cortex aspiration. The epinucleus thankfully has come along with the management of the nucleus itself. Even though I'm in cortex aspiration, the bottle height still is lesser than what typically I use. So the bottle height is maybe around 70 centimeters now. Typically I'd be using around 100 centimeters. The flow rate in the vacuum are also reduced a little bit so the chamber stability is not compromised. So slowly but steadily I am going to aspirate each of these cortical fibers out, and actually in younger patients it's not so difficult. So the one part of the bag is cleared of the cortex. Before switching the hands, again I'm going to use OVD to maintain the chamber. The hands are switched. Then the aspiration of the remaining cortex in the second half of the quadrant is completed. Few tiny opacities are there in the posterior capsule in the central visual axis itself. I'm using a little bit of fluid to just flush them out. I'm extremely scared and reluctant to go and do any sort of polishing to this posterior capsule because of obvious reasons. So just leave those specks there itself. I'm deepening the capsular bag by using OVD. Time to implant the lens. The originally planned single piece hydrophobic lens is being manipulated into the bag. Of course, in all these eyes always have a backup of a multi-piece lens to be placed in the sulcus with optic capture in the eventuality of a posterior capsule tear. And thankfully in this case there is none, and I want to orient the haptics into the meridian where the diameter of the rexis is smaller so that the haptics are getting nicely and snugly fit into the fornices of the capsular bag. The OVD both in front and behind the lens is aspirated out. The anticapsule is polished a little bit. So things are looking alright. In these young patients, the sclera will be very elastic and less rigid. So in these eyes, there's always a propensity for the chamber to shallow and the lens to pop out of the bag. So it's important to keep hydrating the side port incisions and the main incisions to ensure that the chamber is well maintained. And mind you, we should be cautious not to overinflate even during the side port hydration, because even a raise in pressure at the fag end of the surgery can split open the posterior capsule. So be mindful of that. So that's it, the case is done. And these are the first day post-op pictures. The patient is doing pretty well and happy. 3 important messages from this case. The first would be always, I am preferring the oval rexis more often than not in these posterior cataracts. Low flow, low pressure surgery is extremely helpful in minimizing the incidence of PC tears in these vulnerable eyes, especially in the younger age group patients. And third one, whenever we see this sort of a pseudo hole like picture in these polar cataracts, in those situations, the chances of the PC actually tearing seems to be less likely. So that was it. Thank you for watching and hope you found this helpful.